Okay, let's go.
I want to start today with a scenario that plays out in pharmacies basically every single day. And it's just a moment of total confusion.
Oh, yeah, the pharmacy counter realization.
Right, exactly. So imagine you've just been to the doctor and you've been diagnosed with bipolar disorder. Maybe you're, reeling from a manic episode where you didn't sleep for like 4 days.
Yeah.
Or maybe you're stuck in a deep, just immovable depression. You go to the counter, you pick up your prescription, and you look at the little information sheet stapled to the bag.
And you expect it to say for bipolar disorder or mood stabilizer.
Exactly. But instead, in big, bold letters, it says anticonvulsant. It says, for the treatment of seizures.
It's a complete moment of cognitive dissonance for the patient. You're standing there thinking, wait, did the doctor make a mistake?
Right. Did they swap the bags?
Exactly. I don't have epilepsy. Why am I holding a seizure medication?
It totally feels like a mix-up. Or at best, some weird off-label experiment. But as we're going to find out in this deep dive, that isn't a mistake. It is actually the cornerstone of modern psychiatry.
It's the absolute standard, and that's really what makes this deep dive so fascinating. We're unpacking the toolkit of mood stabilizers. And to do that, we effectively have to, raid the epilepsy cabinet.
So our mission today is to clear up that confusion for you. We're going to be looking at a medical primer titled Introduction to Mood Stabilizers and Anticonvulsants. We're going to compare the sort of gold standard treatment against modern alternatives, figure out why a drug designed to stop a seizure can also stop a mood swing.
And we really need to look at the safety warning.
Yes, absolutely crucial.
Because when you borrow heavy-duty tools from neurology, you get heavy-duty side effects. We're talking about everything from tremors to liver toxicity to some very specific and frankly scary skin reactions.
Okay, so let's unpack this before we get into the specific drugs, and we do have quite a roster to get through today. We need to answer the big so what. Right. Why are these two completely different conditions, epilepsy and bipolar disorder, treated with the exact same toolkit?
It comes down to a biological concept called the kindling phenomena.
Kindling, like starting a campfire.
That's actually the perfect visualization. So think about how a campfire starts. You have a massive log, right? That's your brain's baseline stability.
Okay.
If you just hold a match to a big log, nothing happens. It won't catch. You need twigs, you need kindling.
Right. Small sparks catch the twigs catch the branches, and eventually the log burns.
Exactly. So in epilepsy, the theory is that small sub-threshold electrical misfires, these little sparks in the brain, eventually sensitize the neurons.
They lower the threshold.
Yes, they lower the threshold for a major event. Suddenly, a spark that would have totally fizzled out before now triggers a massive, full-blown seizure. The brain has essentially learned how to seize.
And the theory is that bipolar disorder works the same way.
That is the prevailing theory right now. We know the amygdala, which is the part of the brain heavily involved in emotion, is involved in both conditions.
Oh, wow.
Yeah. The idea is that your first manic episode might be triggered by a huge event, a trauma, a death, a massive stressor. But over time, as the brain gets kindled, the episodes start happening spontaneously.
Or just with much smaller triggers.
Exactly.
So the neural pathways for mania are literally being burned in, just like the pathways for a seizure.
In a sense, yes. The brain becomes hyper-reactive. So if the mechanism of the disease is this electrical kindling, it makes perfect sense that the treatment is a fire extinguisher.
We need something that dampens that electrical spark.
Right.
I do want to clarify something, though, because the source material is pretty explicit about this. We are not saying bipolar disorder is a type of epilepsy.
No, absolutely not. They are two distinct diseases, but they share a mechanism. They both involve the brain's voltage, if you will.
Okay, so if we're using these drugs to stabilize mood, we need to define what a mood stabilizer actually is. I always just assumed this was a strict FDA category, like antibiotic or beta blocker, but the primer suggests it's, kind of messy.
Messy is putting it lightly. In medicine, we love strict definitions, but mood stabilizer is a bit of a moving target.
Yeah.
There's no strictly defined rule book for what gets the title. It's more of a functional description than a biological one.
But there are categories, right?
Yeah.
The primer breaks it down into strict, intermediate, and broad definitions.
Right. So if you want to be a purist, the strictest definition is that a mood stabilizer has to do it all. It has to treat acute mania, treat acute depression, and prevent both of them from coming back.
That sounds like a unicorn drug. Does that even exist?
Rarely. Lithium is the closest we have, but even that isn't perfect for everyone. That's why clinically, we usually rely on the intermediate definition.
Which is what?
That's an agent that is effective for either mania or depression and helps with prevention.
And then there's the broadest definition.
Yeah, that's basically it treats one side of the equation without making the other side worse.
Without making the other side worse. I mean, that feels like an incredibly low bar. Why is that even a definition?
Because of how traditional antidepressants work. If you give a standard SSRI, like Prozac or Zoloft, to someone with bipolar disorder, you are playing with fire.
Really?
Yeah. You aren't just treating depression, you risk flipping them straight into a manic episode.
You're destabilizing them.
Precisely. You're pouring gasoline on the kindling. So a true mood stabilizer, at the very absolute least, shouldn't do that. It should treat the symptoms without triggering the opposite pole.
Okay, so we have the what? What about the how?
Yeah.
You mentioned voltage earlier. If we're using anti-seizure meds, we're essentially trying to dampen electrical activity.
Generally, yes. It's about traffic control. Your brain cells send messages using electricity, which is generated by moving ions, sodium, calcium, potassium, in and out of the cell.
Like a battery.
Exactly like a battery. To fire a signal, the cell opens the gates and lets sodium rush in. That's the voltage. What these drugs do, specifically the anticonvulsants, is mess with those gates. They might block the sodium channels, effectively preventing the cell from firing too rapidly.
So it's like a governor on the engine. It stops the brain from redlining.
That's one way. The other way is balancing the chemicals. You have glutamate, which is the gas pedal, the excitatory neurotransmitter, and you have GABA, which is the brake pedal.
So if you're manic, you have too much gas or not enough brakes.
Or both. These drugs are designed to either boost GABA, so slam on the brakes, or inhibit glutamate, ease off the gas.
But here's the catch, and the primer makes a really big point of this. This isn't like taking Tylenol for a headache. You don't just take a mood stabilizer and feel stabilized an hour later.
No. And that is honestly the hardest part of psychiatric treatment. We are changing the biological environment of the brain.
It takes time.
Yeah. You might see some chemical changes in 48 hours, but for a good clinical response where the patient actually feels in control again, you're looking at 1 to 2 weeks. Minimum.
Which can feel like an eternity when you're in a crisis.
Absolutely. That lag time is the danger zone. It's where patients often give up because they think the pills just aren't working.
All right, let's get into the heavy hitters. The source material puts 2 drugs right at the top of the list, almost like rivals. In one corner, we have the old guard, the gold standard, lithium, and in the other, the challenger, valproic acid.
The classic showdown.
Let's start with lithium. This is the one everyone has heard of. But I think most people don't realize that it isn't a pharmaceutical invention at all. It's an element.
Right. It's on the periodic table, right under hydrogen. We aren't synthesizing a complex molecule here. We are literally harvesting salt from the earth.
Wow.
And because it's an element, the human body handles it in a really unique way. It is not metabolized.
Wait, explain that. Because most drugs go to the liver to be broken down, right?
Exactly. The liver is the incinerator. It chops drugs up so your body can get rid of them. Lithium skips the liver entirely. It is excreted almost exclusively by the kidneys.
That sounds like a detail only a pharmacist would care about, but it actually matters a lot for the patient.
It matters immensely. It means if you have a patient with liver problems, lithium might be a much safer bet. But it also means you have to be absolutely obsessive about checking kidney function.
Because if the kidneys slow down...
Think of the kidneys as a filter. If that filter gets clogged or slows down, the lithium just keeps circulating and building up.
And the difference between a therapeutic dose and a toxic dose is really small.
It's razor thin. We call it a narrow therapeutic index. If you get dehydrated or take too much ibuprofen even, your lithium levels can spike into toxicity.
That's terrifying.
It is. You get tremors, confusion, eventually seizures and coma. So patients on lithium are tied to the lab. They need regular blood draws to ensure they're right in that sweet spot.
And the side effects aren't trivial either. We're talking about acne, thyroid disorders.
Yeah, it creates a sort of artificial hypothyroidism in a lot of people. And then there is a very specific, very serious risk if used in pregnancy, Ebstein's anomaly.
That's a cardiac defect, right?
Yes. It's a rare congenital heart defect where the tricuspid valve is displaced. It's directly linked to lithium use in the first trimester. It's a massive consideration for anyone of childbearing age.
So lithium is the gold standard, but it's really high maintenance. You need blood tests for lithium levels, kidney function, thyroid function. It's practically a lifestyle commitment.
It is, but, and this is why it's still the gold standard, it works. Specifically, it has an anti-suicide effect that we just don't clearly see with other medications. For classic bipolar, pure euphoric mania followed by depression, lithium is unmatched.
But not everyone has classic bipolar, and that seems to be where the challenger comes in. Valproic acid, or VPA, sometimes you'll see it called divalproex.
Correct. The clinical picture of bipolar has changed. We see way more mixed states now, where mania isn't happy, it's irritable, angry, agitated. We see patients with comorbid substance use issues or traumatic brain injuries.
And lithium struggles with those.
Lithium is a bit of a diva. It demands a pretty pristine biological system to work best. Valproic acid is much more rugged. It tends to work better for those messy, irritable manias.
And it's faster. The source says therapeutic benefits in 3 to 5 days.
That speed is a huge game changer in an emergency room. If someone is in a severe, acute manic state, you don't have 2 weeks to wait for lithium. You can load VPA, give a high dose immediately to clamp down on the voltage fast.
But unlike lithium, this one is processed by the liver.
Correct. So now the script flips entirely. We aren't as worried about the kidneys, but we are very worried about the liver. It carries a risk of hepatotoxicity, basically liver damage.
And the side effect profile is different too. We're looking at weight gain, hair loss, and something called PCOS.
Polycystic ovary syndrome. It's a significant risk for women. It can disrupt the hormonal cycle and increase testosterone levels.
Oh, yeah.
And going back to pregnancy, VPA is arguably worse than lithium. It is a known teratogen. It causes neural tube defects like spina bifida.
So you have to be incredibly careful.
Most guidelines say you simply should not use VPA in women of childbearing age unless there is absolutely no other option.
So we have the kidney and thyroid path with lithium and the liver and PCOS path with VPA. Both have pretty heavy baggage. What happens when neither works? Or what if the side effects are just too much? Then we start looking at the alternatives.
Right.
And this is where we run into a drug that sounds like it's straight out of a sci-fi movie. Carbamazepine.
Ah, yes. The drug that eats itself.
The source describes a pharmacokinetic quirk called autoinduction. Can you explain that in plain English?
It is honestly one of the wildest things in pharmacology. When you take a drug, your liver uses enzymes to break it down. Carbamazepine is metabolized by an enzyme called CYP3A4.
Yep.
But here's the kicker. Carbamazepine actually tells the liver to make more of that enzyme.
So it basically trains the assassin to kill it faster.
Exactly. You prescribe a dose and it works great for 3 weeks. The patient feels totally stable. Then suddenly they relapse into mania.
Because it's gone.
Right, because the liver has ramped up production of the demolition crew enzymes and is now chewing through the drug twice as fast.
That sounds like a dosing nightmare.
It is. You're constantly chasing a moving target. And because it ramps up those enzymes, it doesn't just chew up carbamazepine. It chews up everything else the enzyme works on. It interacts with many other drugs.
Like what?
Birth control pills, for one. That's a massive issue. It can render oral contraceptives completely ineffective. It messes with anticoagulants, antipsychotics. It's a dirty drug in terms of interactions.
The source lists it as having potent CYP interactions. Potent feels like an understatement.
It is, and the safety profile is pretty serious too. A granulocytosis, which means a severe drop in white blood cells, aplastic anemia, and severe skin rashes like Stevens-Johnson syndrome or SJS.
We're going to talk more about SJS in a minute because it comes up again. But before that, is there a way to get the benefits of carbamazepine without the self-eating nightmare?
Enter oxcarbazepine. Think of it as carbamazepine 2.0, the software update.
The source says it has no autoinduction.
Right. It's structurally similar, but it doesn't trick the liver into revving up, so the dosing is steadier and the drug interactions are far fewer.
But it's not risk-free.
Yeah.
There's a specific warning here for hyponatremia.
Low sodium levels. It's much more common with oxcarbazepine. So instead of watching the liver or white blood cells, you're watching salt levels. If sodium drops too low, you get confusion, lethargy, and, yes, seizures.
There's no free lunch in pharmacology, is there?
Never. You're always trading one risk profile for another.
Okay, so we've covered the gold standard, the fast challenger, and the self-eating enzyme inducer. But there is one drug in the source material that is explicitly labeled as an outlier.
Lamotrigine.
Why is it the outlier?
Because it breaks the mania first rule. Most of the drugs we've discussed, lithium, VPA, carbamazepine, they're great at stopping mania. They crush the high voltage.
Right.
Lamotrigine is different. It is not useful for acute mania.
Really? So if someone is in a manic episode, this literally does nothing.
Very little. It's too slow, and it doesn't have that heavy capping effect, but it is the absolute specialist for bipolar depression.
And that's a huge distinction, because bipolar patients often spend way more time depressed than they do manic.
Exactly. Lamotrigine lifts the floor without blowing off the roof. It's arguably the best maintenance drug for preventing the depressive crash.
And there's another big pro column for lamotrigine: pregnancy.
It is noted as safe in pregnancy, which, as we've seen with lithium and VPA, is a rare quality in this class of drugs. It doesn't carry those terrifying heart or neural tube defect risks.
But, and there's always a massive but, we have to talk about the rash again.
Yes. The black box warning for Stevens-Johnson syndrome, SJS. It's a rare but potentially life-threatening skin reaction where the skin literally blisters and peels off. It's a medical emergency.
And the source says the risk is tied directly to speed.
Correct. You cannot rush lamotrigine. You have to titrate. You start with a tiny baby dose, 25 milligrams for 2 weeks, then 50 milligrams for 2 weeks, then 100 milligrams.
Wow.
It takes a month or more to get to a working dose.
Start low and go slow.
That's the mantra. If you rush it, the risk of the rash skyrockets.
Now, here is where it gets really interesting and dangerous. We talked about valproic acid earlier. What happens if a patient is taking valproic acid and you add lamotrigine?
This is the do not cross the streams moment of mood stabilizers. It's a classic board exam question and a critical clinical trap. Valproic acid inhibits glucuronidation.
Glucuronidation is how the body gets rid of lamotrigine.
Exactly. So VPA locks the exit door. If you take them together, the levels of lamotrigine in the blood can spike dangerously high, doubling or even tripling.
Which would skyrocket the risk of that deadly rash.
Precisely. It doesn't mean you can't use them together. Sometimes you really need both, but you have to be incredibly skilled. You usually have to cut the lamotrigine dose in half, literally. It's a major red flag interaction.
I want to zoom out a bit. We've talked a lot about physical side effects, liver, kidneys, skin, but there are also warnings about the mind itself. The source mentions a 2008 FDA alert regarding suicide.
This is a point of significant controversy in the medical community.
What actually happened in 2008?
The FDA analyzed data from nearly 200 clinical trials of anticonvulsants, mostly for epilepsy, and issued a warning that the entire class of drugs increased the risk of suicidal ideation and behaviors. They put the number at about 2 per 1,000.
That sounds significant.
It is serious. But here's the criticism, and the source is quite clear on this. The FDA lumped all these drugs together. When you actually look at the data, statistical significance was only found in 2 drugs, topiramate and lamotrigine.
But they applied the warning to the whole class, even the ones that showed no risk.
To all of them, even the ones that might actually be protective.
What's the current consensus? Is it safe?
Subsequent meta-analyses have found no evidence of increased risk for the class as a whole. The source says the true risk is likely very low, but because of that alert, the warning label remains.
That's tough.
It creates a paradox where we prescribe a drug to prevent suicide, but the bottle warns the patient it might cause it.
That requires a lot of trust and explanation between the doctor and patient for you to navigate.
It does. It's a reminder to always monitor mood, which you should be doing anyway with these patients.
There's one other side effect mentioned for almost all these drugs, and it affects the listener for sure. You know, anyone who values their sharp mind. Cognitive dulling.
The brain fog. This is the quality of life killer.
Is it inevitable? Like, if you dampen the voltage to stop the mania, do you dampen the brilliance too?
To an extent, yes. Patients often describe it as feeling just a little slower. They have trouble finding words, or their memory isn't quite as sharp. They feel flat.
Is the trade-off for damping down that excess voltage?
Exactly. You turn down the noise, but you might turn down the signal a bit too. It's often the number one reason people stop taking their meds.
Yeah.
They miss the spark. They miss the speed of their own thoughts. Our job is to find the lowest effective dose that keeps them safe without turning them into a zombie.
This has been a lot to take in. It really highlights how complex this toolkit is. We aren't just fixing a broken bone here.
No. We are trying to tune a high-performance engine while it's running at 200 miles per hour.
Let's try to summarize the main takeaways for you all. If we are treating bipolar disorder, we're often borrowing from the epilepsy shelf because of that shared kindling biology, stopping the spark.
Correct.
If we want the gold standard, we go to lithium. Unmatched for classic mania and suicide prevention. But you have to live the lithium lifestyle, hydration, blood tests, and watching the kidneys and thyroid.
And very careful cardiac monitoring if pregnancy is a possibility.
If we need speed, or the patient has messy mania or kidney issues, we might look at valproic acid.
Right. The liver-focused, fast-acting alternative. Great for complex cases, but watch out for weight gain, hair loss, and neural tube defects.
If we need an alternative, we have carbamazepine, the self-eater that interacts with everything, or its cleaner cousin, oxcarbazepine, where we just have to watch the salt.
Exactly.
And finally, the outlier, lamotrigine.
The depression specialist. Safe for pregnancy, lifts the floor, but requires a slow, careful start to avoid the rash. And keep it away from VPA unless you really know what you're doing.
It's fascinating how we categorize these. We call them mood stabilizers, but as you said, that's not really a strict medical term.
It isn't. And that actually leads me to the thought I want to leave everyone with today.
What's that?
We are treating these conditions based on symptoms. We see mania. We give a drug that dampens voltage. We see depression. We give a drug that lifts it. But we're essentially treating the smoke, not the fire.
Right. We're just managing the output.
If mood stabilizer is just a loose bucket for things that help, and we are borrowing tools from epilepsy to fix it, it really highlights how much we still have to learn about the brain's electrical system. We are managing the voltage, but we still don't fully understand the generator.
The fact that an element like lithium, just simple salt, works so well, and we still don't know exactly why, proves that there is still plenty of mystery left in the circuitry.
Always more to learn.
Thanks for joining us for this deep dive. We'll catch you on the next one.